Hello class, today we're going to talk about post-operative nausea and vomiting in geriatrics. This presentation is presented by Hilary Gursky and Brooke Liston. Our objectives for this presentation are as follows. First, we're going to talk about post-operative nausea and vomiting, also known as PONV. We're going to talk about the pathophysiology of PONV, certain risk factors that are associated with increased risk of PONV, medications that are important to avoid in the geriatric population, some strategies for non-pharmacological management. We are going to go over a case study of a geriatric patient, and finally we're going to have a couple of review questions to see what information you learned during this presentation. So first, let's talk about the background about PONV. Post-operative nausea and vomiting is defined as nausea and/or vomiting occurring within 24 hours of surgery. The incidence of post-operative nausea and vomiting occurs in 30 to 40% of all patients who undergo anesthesia, but in patients with identified risk factors, the incidence can be up to 70 to 80%. PONV is one of the most feared negative side effects of anesthesia. In a study of 195 surgical patients, the patients ranked emesis as the most important anesthesia outcome that they feared over gagging on the endotracheal tube, pain, nausea, and intraoperative recall. On this slide, we will talk about the pathophysiology of nausea and vomiting. Nausea is the subjective feeling of the need to vomit. It is a very unpleasant feeling for the patient. Emesis is the expulsion of stomach contents up the esophagus to the mouth. It may or may not be preceded by nausea. The process of expelling the gastric contents involves the closure of the glottis and the contraction of the diaphragm. This creates negative intrathoracic pressure at the same time the pharyngeal sphincters relax. Almost simultaneously, abdominal muscles contract, creating increased intra-abdominal pressure, which is transferred to the stomach, then emesis occurs. These events are controlled by the vomiting center, which lies in the medulla oblongata. Slightly cephalad to the vomiting center is the chemoreceptor triggering zone, also known as the CTZ. Since the CTZ is located outside the blood-brain barrier, it is sensitive to drugs and toxins in the bloodstream. It can sense these toxins, for example, high ethanol concentrations, and sends signals to the vomiting center. The CTZ responds to many neurotransmitters. These include histamine via H1 receptors, dopamine via D2 receptors, serotonin via 5-HT3 receptors, and acetylcholine via muscarinic receptors from the vestibular apparatus. Recently, neurokinin 1 was found to play a role in the emetic reflex. In this picture, you can see how close the medulla and the fourth ventricle are located. Risk factors for PONV can be related to the patient, anesthesia, the type and length of surgery. So some patient risk factors are gender, female greater than male, history of motion sickness or PONV, if the patient is a non-smoker, and use of opioids post-operative or during the case. Women are at higher risk for post-operative nausea and vomiting because the effects of progesterone and/or estrogen on the chemoreceptor triggering zone or on the vomiting center itself, as evidenced by the fact that PONV varies within the menstrual cycle and is reduced after menopause. This is important for the geriatric patient since they will have already gone through menopause and the female risk factor may not be as significant for them. It is actually shown that the actual risk of PONV is reduced with aging. You always want to assess your patient if they've had a history of postoperative nausea and vomiting in the past, or maybe they got motion sickness on roller coasters or cruise ships before. This could increase their risk. Some anesthesia and surgery risks are use of volatile anesthetics and nitrous oxide, general versus regional anesthesia, use of intraoperative and postoperative opioids, and longer duration of surgery. The inhalational anesthetics, nitrous oxide, neostigmine, and opioids all have been implicated in the genesis of PONV. To avoid some of these pro-emetic drugs, you can use Ativa with propofol. Opioid-free technique can be used to decrease the likelihood. The length of surgery is important because a longer surgery, the longer the patient is exposed to emetogenic lipophilic drugs. Some surgeries are actually associated with an increased incidence of PONVs, independent of duration. These include laparotomies, gynecologic surgeries, laparoscopic procedures, ear, nose, throat, breast, plastic, and orthopedic surgical procedures. Regional anesthesia is indicated with a decreased risk of postoperative nausea and vomiting as compared to general anesthesia. This chart is from the best practice guidelines from the American College of Surgeons and the American Geriatrics Society. It is titled Summary of Medications Commonly Used for PONV Prophylaxis and Treatment in Adults. It provides guidance to the anesthesia provider on which drugs to potentially avoid for PONV in the geriatric population. They recommend caution in 5-HT3 receptor antagonists due to the risk of serotonin syndrome and QT prolongation. In the clinical setting, you will see ondansetron given to geriatric patients quite frequently. If the patient has been diagnosed with depression, make sure to carefully assess their medication list. Many antidepressants increase serotonin. Be careful if you plan to administer a 5-HT3 receptor antagonist. The anesthesia provider must know the signs and symptoms of serotonin syndrome, including agitation, confusion, tachycardia, hypertension, dilated pupils, diaphoresis, loss of muscle coordination, shivering, and more. Also, it's important to look at their EKG to make sure they don't have a prolonged QT before administering a 5-HT3 receptor antagonist. Corticosteroids also may induce or worsen delirium. Careful selection of patients to administer popular antiemetics like Decadron is important. Transdermal scopolamine should not be given to geriatric patients. According to the FDA, use with caution in the elderly because of the increased likelihood of CNS effects such as hallucinations, confusion, and dizziness. Scopolamine should be used with cautions in patients with impaired renal or hepatic function because of the increased likelihood of CNS effects. We know that many of the geriatric patients have impaired renal or hepatic function, so scopolamine should be avoided in all geriatric patients. Scopolamine is a high-affinity selective competitor antagonist of G-protein-coupled muscarinic receptor for acetylcholine. Scopolamine penetrates the blood-brain barrier, readily blocking cholinergic transmission in the CNS. It is well demonstrated that the elderly are much more sensitive to the cognitive effects of scopolamine than young individuals, probably due to the central cholinergic syndrome deficits associated with aging. Metoclopramide and droperidol should absolutely not be given to patients with Parkinson's disease. They are both dopamine antagonists, and the goal of treatment for Parkinson's is to increase the dopamine in the brain. Droperidol has fallen out of popularity in clinical practice after the FDA placed a black box restriction due to its association with prolonged QT syndrome. All anticholinergic drugs can increase the risk for delirium and cognitive impairment. It is important for the anesthesia provider to be aware of the mechanism of action of all of the commonly used antiemetic drugs. Many geriatric patients are on several prescription drugs that may change your prophylactic medication plan to prevent postoperative nausea and vomiting. On this slide, I will tell you a case study about an 80-year-old woman who used a transdermal scopolamine patch. A healthy, young-looking, intelligent, and cheerful 80-year-old woman was evaluated at the Houston Methodist Hospital Memory Clinic because of an episode of scopolamine intoxication that occurred on November 12, 2010. She flew from Texas to Hawaii and prior to boarding a cruise ship, applied a post-auricular transdermal scopolamine patch to prevent seasickness. Her last memories of the vacation include arriving to Hawaii and boarding the cruise ship. She has no recollection after becoming confused, delirious, agitated, and experiencing visual hallucinations. Because of her markedly altered mental status, she was disembarked, admitted to a local hospital in Hawaii, and eventually was flown back to Texas 5 days later. Her neurological and neuropsychological evaluation was consistent with mild cognitive impairment, and on November 30th, 2010, you can see here her PET brain scan showed markedly increased tracer uptake in the basal ganglia bilaterally. Thankfully, she completely recovered from this episode, and a PET scan was repeated on October 25th, 2011, showing a near normal tracer distribution in the basal ganglia and cortex.
Utilizing non-pharmacological methods to avoid post-op nausea and vomiting is beneficial in the geriatric patient population. The P6 pressure point has been postulated as a useful prophylactic measure to prevent PONV. The P6 point lies 5 centimeters proximal to the ventral wrist crease between the flexor carpi radialis and the palmaris longus. Stimulation should occur before induction of anesthesia for appropriate results. Isopropyl alcohol and aromatherapy, such as peppermint oil, can be helpful for patients to smell in the PACU to decrease episodes of nausea and vomiting. All of our patients coming into surgery are dehydrated from the NPO guidelines. The geriatric population may be at an increased risk. As anesthesia providers, it's important to make sure that our patients are well hydrated. Using IV fluids to hydrate our patients can decrease periods of hypotension intraop. Decreased perfusion to the gut, secondary to hypotension, can lead to a release of serotonin and can stimulate vagal afferents in the chemotriggering zone. Preoperative anxiety can be associated with the fear of having post-op nausea and vomiting. Good communication between the anesthesia provider and the patient can decrease anxiety and build rapport. APFEL risk score is pretty well known and commonly used. It's really a beneficial tool to help determine which patient is at risk and the prevalence of developing post-op nausea and vomiting. By knowing the APFEL score of your patient, it can help guide your clinical practice for prevention. These risk factors are based on female gender, non-smoker, history of post-op nausea and vomiting, or motion sickness, and opioid use. With 0 risk factors, your risk of post-op nausea vomiting is already 10%. With 1 risk factor, you're at 21%, 2, 39%, 3, 61%, and 4, 79%. Here, a table is provided of Stanford Medicine's post-op nausea vomiting prophylaxis guidelines based on APFEL risk score. This gives the risk score, the prevalence, the number of prophylaxis antiemetics, and examples of medications to be administered. Even with 0 risk factors, the prevalence of PONV is 9% and should receive 4 milligrams of ondansetron. As the risk scores increase, Decadron, propofol infusion, and a scopolamine patch can be administered in combination to decrease the risk. Although these are recommendations, ondansetron should be administered with caution due to the risk of serotonin syndrome, and also scopolamine should be avoided in the geriatric population. The Society of Ambulatory Anesthesia, also known as SAMBA, offers clinical practice guidelines and recommendations for antiemetic prophylaxis and treatment for PONV. SAMBA consensus guidelines is supported by the AANA. A case study was performed on a relatively healthy 81-year-old male that was undergoing a sigmoid colectomy to treat his colorectal cancer. He is currently not taking any medications at home and quit smoking over 30 years ago. He has previously received anesthesia twice, both without complications. He also denies any issues with post-op nausea vomiting and does not admit to any motion sickness. This case study will demonstrate how to determine the patient's risk factors for PONV and multiple ways to reduce the risk. So for the anesthetic and surgical plan of the case study, the patient had a midline incision for a laparotomy. The surgery was approximately 4 hours. Total intravenous anesthesia was used with administration of propofol for both induction and maintenance. For pain management, the patient received remifentanil intra-op as adjunct with the TIVA. He also had a thoracic epidural placed for effective pain relief in the postoperative period. Risk factors can be separated into patient factors, surgical factors, and pharmacological factors. As mentioned previously, patient risk factors include female gender, history of PONV or motion sickness, age less than 50, and being a non-smoker. The only risk factor the patient has in this case study is being a non-smoker. Smoking is thought to be a protective risk factor due to the desensitization of the chemotriggering zone. As you age, the risk of PONV decreases, so with this case study being a geriatric patient, it decreases his risk. Female experience post-op nausea and vomiting 2 to 3 times more often than males. Below are a list of surgical factors that will increase your risk of post-op nausea and vomiting: a laparoscopy, laparotomy, ENT surgery, neurological surgery, breast or GYN surgery, increased duration of surgery, and pain. Surgical risk factors that are pertinent to the patient's case study include a laparotomy surgical procedure, the length of surgery being 4 hours, and pain from the surgery. This patient had a midline incision, which can stimulate the vagus nerve and produce emetogenic effects. Pharmacological factors that increase post-op nausea and vomiting include the use of volatile anesthetics, the use of nitrous oxide, reversal agents such as neostigmine, and the use of opioids, whether it's intra-op or post-op. General anesthesia can increase PONV by 11-fold. Volatile agents were avoided and a TIVA was performed. No reversals were required, so neostigmine was avoided, as well as the emetic effect from neostigmine. Pain is a very common cause of emesis. With effective pain relief, you can prevent nausea and vomiting. This patient received a thoracic epidural. They also used remifentanil to control the pain intra-op. Although remifentanil will relieve the pain, it also increases his risk of PONV. The use of opioids strongly correlate with post-op nausea vomiting. Their rationale was that the emetic effect of opioids can be minimized by using shorter-acting opioids. Other factors increasing the risk of PONV are poor bag mask ventilation, which will increase gastric distension and subsequent nausea, poor hydration during or immediately following surgery, intra-op hypotension, as well as patient stress and anxiety. This patient was kept well hydrated with 3 liters of LR. Since this was a study from Scotland, they use gelifusин, which is a colloidal volume replacement that is modified fluid gelatin. Patient was well oxygenated, which has also been shown to decrease PONV by 50%. For the treatment of hypotension, ephedrine was used. Key points to take away from this case study are to calculate your patient's baseline risk of post-op nausea and vomiting, adjust your anesthetic plan to reduce the risk. Monotherapy or combination therapy should be used for patients with moderate risk. Double or triple therapy may be needed for high-risk patients. Rescue therapy antiemetics should be different from what was administered for prophylaxis of PONV. Just remember, sometimes it's easier to prevent PONV than it is to treat it, and that each patient should be considered individually. Which of the following antiemetics are associated with serotonin syndrome? A. Ondansetron, B. Promethazine, C, metoclopramide, or D, aprepitant? The answers are A, ondansetron, and C, metoclopramide. Nagelhout states that it can be caused by the individual drug, an overdose, or most commonly a drug interaction. The mechanism is thought to be increased serotonergic activity through an excess of serotonin precursors, or agonist, increased serotonin release, reduced serotonin uptake, and decreased serotonin metabolism, which can be found on Nagelhout, page 198. Which antiemetic should be avoided in patients with Parkinson's disease? Select 2. A, propofol, B, metoclopramide, C, ondansetron, and D, droperidol. The answers are B, metoclopramide, and D, droperidol. These may cause extrapyramidal side effects and is contraindicated in patients with Parkinson's disease. And this concludes our presentation on post-op nausea vomiting in the geriatric population.